Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is fetal aneuploidy screening in pregnancy or genetic screening in pregnancy with mainly focusing on the important concepts. Definition of aneuploidy is in humans is it is the deviation from normal number of 46 chromosomes or 23 pairs, and it occurs because of the error during either meiosis or mitosis. Common aneuploidies are trisomy 21, trisomy 18, trisomy 13. Sex chromosomal abnormalities come next in the frequency if we see the overall aneuploidies, where either there can be 45X, that is Turner syndrome, or 47XXX, XXY, or XYY. So here, as we can see here, the commonest aneuploidy, if we see it is the trisomy 21, where instead of 2 chromosomes, we will be having 3 chromosomes. Followed then trisomy 18, trisomy 13, and related to the sex chromosomal abnormalities, we can have various abnormalities. If we see the distribution, the major chunk, that is 50%, is occupied by the trisomy 21 or Down syndrome. If we see all the distribution of aneuploidies. Followed by Down syndrome, we have trisomy 18, that is Edward syndrome, which is contributing to 15% of all the aneuploidies. Followed by that, we have sex chromosomal abnormalities, which are contributing to 12%. And in 5%, we can have trisomy 13, that is Patau syndrome. Whereas the rest, all the others contribute for 18%. Apart from these, mainly 3 trisomies, that is autosomal and sex chromosomal abnormalities together, these are responsible for around 82%, whereas 18% are because of the abnormalities, which are all the other chromosomal abnormalities contribute for this 18% of the total number of the aneuploidies. In the risk factor for aneuploidy, maternal age greater than 35 years is number one. Second is there can be numerical or structural chromosomal abnormality in either of the parents. For example, balanced translocation. Now here, as we can see, balanced translocation is of two types, reciprocal and Robertsonian. In reciprocal, there is an exchange of genetic material between the two chromosomes, as we can see here, that instead of this is normal, instead of that there is an exchange, and that leads to balanced translocation, means the person is carrying it, but there is a balance, so that there is no phenotypic change or there are no major adverse effects of this exchange of the genetic material. But whenever it gets transmitted, only one part gets transmitted, this balance is lost and the fetus might be having major aneuploidies. Whereas Robertsonian is where there is a joining of two chromosomes with each other. So that with the Robertsonian, number of chromosomes will be reduced. Instead of 46, the person will have 45 chromosomes. Whereas here the number of chromosomes is same, but there is a structural abnormality. So that is how either of the parents can have either structural abnormality, that is reciprocal type of balance translocation, or there can be a numerical abnormality in either of the parents because of Robertsonian type of balance translocation. Third risk factor is previous baby having any autosomal trisomy or triploidy. Triploidy is where the number of chromosomes is rather than 46, that is 23 is the single number, and 2n comes to 46, whereas 3n comes to 69. So in triploidy, person will be having 69 chromosomes. Now, what is the meaning of screening test and what is the meaning of diagnostic test for aneuploidy? As we all know, screening is where we are mainly focusing on selecting the high risk population where we can further test and diagnose a condition. That is, for example, for cervical malignancy, screening test can be either a HPV testing or it can be cervical cytology, but diagnostic test will always be cervical biopsy to diagnose either a cervical intraepithelial neoplasia or cervical carcinoma. Similarly, for aneuploidy also screening tests are only selecting the cases where there is a greater risk of having aneuploidy. And for confirmation of diagnosis, always we have to proceed with the diagnostic test. So for screening tests, what are the screening tests? Screening test is where we can do maternal blood test for PA-PPA. PA-PPA is pregnancy associated plasma protein A, estriol, SCG level, along with this nuchal translucency by ultrasonography. Or one can do another screening test, that is maternal blood test for cell-free fetal DNA. So mainly we have these two options as screening test. One is we do the maternal serum testing for various analytes. Analytes are the substances which can, where the chemically they can be measured. That is the definition of analyte. If you read many textbooks, you will be even you will find that the name for this test, PAPPA, histriol, SCG, that is called as analyte testing. Analyte testing is where, or there can be alpha fetoprotein also as one of the component, maternal serum alpha fetoprotein. So all these blood tests together are called as analyte testing. Analyte is a, by definition, is a substance which has a chemical structure because of which we can measure its content in any medium. Here we are measuring the PAPPA level in the maternal blood, estriol level in maternal blood, maternal serum alpha fetoprotein level, or HCG level in the maternal blood. Here HCG is mainly the free beta HCG, that is unbound form of beta HCG. And nuchal translucency by ultrasonography. That is one way. Or one can go for maternal blood test for cell-free fetal DNA. These are both are screening tests. The screening test identify high-risk group for aneuploidy. Positive predictive value is better for any of the tests whenever the maternal age is greater than 35 years. Test Both of these tests, these can come as either false positive or negative, and that is the reason definitive interventions are not recommended on the basis of results of these screening tests, because even any test you do, whatever combination you do take, still always there is a risk of having a false positive result or a false negative result, and that is the reason these are not considered as diagnostic tests. In the diagnostic test, we have two tests, that is Korean test, that is Korean villus sampling and amniocentesis. On the basis of these, we can take decisions about either termination of pregnancy or continuation of pregnancy after the proper counseling of a patient. Now, these diagnostic tests are invasive as opposed to the screening tests, which are non-invasive, and that is why these diagnostic tests are not used for screening, because these are invasive and these are associated with pregnancy procedure related complications. Coming to aneuploidy screening tests, we have, as we have already seen, there are two tests: Analyte based test and cell-free fetal DNA based test. No screening test is diagnostic. No one test is superior to the other is another concept which is very, very important. Most important is no screening test is diagnostic. You should never consider even this cell-free fetal DNA as diagnostic. It is not diagnostic, and no one test is superior to other. Positive predictive value is higher whenever the maternal age is greater than 35 years. Diagnostic tests are mandatory before further action, as we have already seen in the further previous slide. Now, there are certain situations where aneuploidy screening is not done or it has no place in the management. And these situations are whenever you detect a major congenital malformation by ultrasonography, then it is an indication to go for directly for a diagnostic test rather than going for a screening test. So if you, for example, we see cystic hygroma, there is such a high risk of having aneuploidy. 50 to 70% of the cases of cystic hygroma can have chromosomal abnormalities. So it is an indication for directly going for either chorion villus sampling if you detect it earlier, or in the second trimester you have to go for amniocentesis. There is no place to go for either analyte based or cell free fetal DNA testing because the risk is very high. Second, if there is a presence of neural tube defect, then these screening tests have a questionable place because the presence of neural tube defect or ventral wall defect, or both of these, there is secretion of alpha fetoprotein into the amniotic fluid and in the maternal as well as into the maternal circulation, and that affects the result of this analyte based testing, especially the second trimester. If we detect neural tube defect or ventral wall defect, it will be an indication to directly go for diagnostic test rather than then going for a quadruple test which includes alpha fetoprotein. In twin pregnancy, though we can do aneuploidy screening, it is less accurate as compared to the singleton pregnancy, but it is invalid in triplets or higher order pregnancies because of the gross inaccuracy in these cases. And whenever a woman does not want screening, then we should not be forcing it, is another important concept. The decision should be entirely a woman's decision. We have to counsel, we have to provide the information, and at the end of the discussion, it is up to the woman to decide whether to go ahead with screening test or diagnostic test or not. If we compare these two aneuploidy screening tests, for one is analyte based test and other is a cell-free fetal DNA. Comparatively, analyte based tests are cheaper. Then they under the umbrella of these analyte based tests, we can detect many more chromosomal abnormalities apart from the common ones which we have seen. Common ones are trisomy 21, 18, and 13, and sex chromosomal abnormalities. But apart from that, 18% is a major chunk, which is because of the other chromosomal defects, and all these can be uh, for all these screening can be done based on this analyte based test, whereas with cell-free fetal DNA, we can test only for specific aneuploidy. That means trisomy 21, 18, 13, and sex chromosomal abnormality. With a lesser accuracy, we can go for the screening with the help of this cell-free fetal DNA. It is expensive as compared to analyte based testing. Analyte based test also can be a method for screening for neural tube defects. That is another thing. Whereas this cell-free fetal DNA does not help us to screen for neural tube defects because of the increase in maternal serum alpha fetoprotein. We can consider this analyte based test as a screening test apart from aneuploidy also for neural tube defects. Analyte based tests are done either at 10 to 14 weeks, and that is earlier first trimester, or 15 to 20 weeks, that is second trimester. Whereas cell-free fetal DNA advantage is it can be done any time after 10 weeks of pregnancy. Analyte based tests have moderate sensitivity and specificity, whereas this cell-free fetal DNA is associated with a higher sensitivity and specificity. There are more false positives with analyte based, especially whenever a woman is young with an age less than 35 years, whereas false positives are less with the cell-free fetal DNA. Both are non-invasive. On the other hand, this cell-free fetal DNA, the other name which was used previously and it is still used in many textbooks is it is called as NIPT. That is non-invasive prenatal test. It is a terminology which is used by some authors as well as some textbooks also for this cell-free fetal DNA. But this is a better terminology because even analyte-based tests are also non-invasive prenatal tests. Test results you get in 1 to 2 weeks with both of the types of screening tests. But analyte based tests are better suited for universal screening because they are more easily available, cheaper, and almost all the chromosomal abnormalities for all the chromosomal abnormalities screening can be done with the help of these analyte based tests. Whereas to rule out specific abnormalities, better will be cell-free fetal DNA. So this is better suited for high risk group. Now, what exactly is this cell-free fetal DNA, which is also known as non-invasive prenatal test or NIPT? Now, remember that cell-free fetal DNA is a misnomer. Now, this is interesting that it is such a common term which is used, this cell-free fetal DNA, that we almost consider that it must be the fetal cell which is or fetal DNA which we must be detecting, but it is not fetal. It is the DNA fragments of apoptotic trophoblastic cells, which are detected in the maternal circulation. Apoptosis is maternal placental cells which are undergoing programmed cell death. Programmed cell death is apoptosis, and these are placental cells which are undergoing this programmed cell death. These trophoblastic cells are detected into the maternal circulation. So, in other words, it is cell-free trophoblastic DNA which is actually being studied by when we do this test. These fragments of DNA fragments are present in maternal circulation. Cell-free fetal DNA fragments are smaller as compared to maternal DNA fragments. Now here, as you can see, from the placenta, trophoblastic cells enter into the maternal circulation, which these DNA fragments enter here, which are because DNA fragments are because the cell is going for apoptosis or programmed cell death. So that is why DNA fragments are released into the maternal circulation, which are smaller. These red ones are these cell-free fetal DNA, or on to be more precise, cell-free trophoblastic DNA, which are smaller in size as compared to cell-free maternal DNA fragments. So maternal circulation has cell-free DNA in the form of maternal DNA as well as these trophoblastic DNA fragments. But how it is segregated is by centrifugation, is because on the basis of the size there are various techniques. Better techniques are also now used, but for segregation or separation of these maternal DNA fragments from fetal DNA, cell-free fetal DNA fragments. Now, fetal fraction is the amount of this cell-free fetal DNA in the total cell-free DNA. Total DNA upon total cell-free DNA divided by cell-free fetal DNA gives you the fetal fraction, and usually it is around 10%. If it is anytime less than 4%, it is considered as low, and in these situations, the test result is considered as indeterminate or inconclusive. What are the limitations of cell-free fetal DNA? Though it has high sensitivity and specificity, around more than 98% it is given in by textbooks, but still it is not 100% diagnostic. So it is not still a diagnostic test, it is a screening test only. Positive predictive value is best for trisomy 21, whereas comparatively positive predictive value is less for trisomy 18 or trisomy 13. Lower positive predictive value for other genetic abnormalities. Apart from these three, if you test for other genetic abnormalities, the positive predictive value keeps on reducing because the positive predictive value also is dependent on the prevalence of that condition in that general population. Now, for sex chromosome abnormalities also, positive predictive value with this test is lower. Now, this test, that is cell-free fetal DNA, is not offered whenever there is a positive Analyte test. That means if you do Analyte test and it comes positive, as a second step, you don't advise this cell-free fetal DNA because it is not diagnostic, and so many times you are wasting the precious time rather than going for taking a decision to proceed with the diagnostic test, because there is a small chunk of a group of patients which will remain undiagnosed in spite of repeating the cell-free fetal DNA with a positive Analyte test also. Mainly here we want to know whether the Analyte test, if it is positive, whether it is a false positive or true positive. For that, what is best next step will be to go proceed with the diagnostics test and not with this cell-free fetal DNA is the important concept. I hope you have understood that. Suppose you have done a Analyte test and that has come positive that there is a risk of aneuploidy. In that situation, you don't do cell-free fetal DNA as a second test. The reason is it is also not diagnostic. It is only it will only be again a screening. Though it comes positive, still there will also be a small risk of having either small positivity or false positivity or false negativity also. And that is the reason in these cases we have to proceed with diagnostic test, amniocentesis or chorion villus sampling. In 2 to 4% of the women, the report comes as no call. What is no call with cell-free fetal DNA is, yeah, there is the fetal fraction is less than 4%. So it is either called as no call result, indeterminate result, or no result. These three terminologies, the meaning is same. The pathology lab will give the report as either no call, indeterminate, or no result, and it is because of a low fetal fraction where the fetal fraction is less than 4%. Usually it is around 10%. So if now why there is this no call, no result or indeterminate cell-free fetal DNA result? It can be because of there are three possibilities. Either there can be a we have miscalculated the gestational age and done it. As we have already seen, it can be done anytime after 10 weeks of pregnancy. But gestational age, if it is less than 10 weeks, that might be the reason why fetal fraction is less than 4%. Obesity is another, and in trisomy 18 and 13, whenever there is an aneuploidy, there is an increased risk of having this no call result. So on the other hand, whenever there is a no result or indeterminate result, we are more worried because one of the possibility is baby having aneuploidy, especially trisomy 18 or trisomy 13. If you get suppose we do cell-free fetal DNA and the test report comes positive for aneuploidy, and then you proceed with chorion villus sampling and the report comes negative. That means our report was false positive. So what are the causes of false positive cell-free fetal DNA? False positive is report is showing aneuploidy but baby is normal. It can be because of a placental mosaicism, where there is a limitation of mosaicism only to the trophoblastic cells. It is not going to the fetal cells. It is contained in or limited to the placental mosaicism. So trophoblastic cell mosaicism can lead to this false positivity, because though we call it as fetal DNA, we are actually studying the trophoblastic DNA, and in some cases there can be a difference between trophoblastic DNA and fetal DNA. Early demise of aneuploid co-twin can lead to false positivity. The co-twin which was aneuploid, and if there is a demise of that co-twin, then the pregnancy will present as a vanishing twin. As we said, vanishing twin, that previous ultrasonography showing supposed twins, and you repeat after a few weeks and you find that now there is only a singleton pregnancy. So this early demise of one of the twin, and that twin is having aneuploidy, that can lead to this false positivity. So whenever there is a ultrasonography showing a empty second gestational sac, then this cell-free fetal DNA is not recommended as a test of choice for screening because the result will be inconclusive. Maternal aneuploidy will lead to this false positivity. Maternal mosaicism can be there, and rarely remember that there can be occult maternal malignancy. Though rare, that is also one of the possibility which can lead to the false positive cell-free fetal DNA test. Whenever there is a positive test or whenever there is a no call, that is indeterminate cell-free fetal DNA test result, it is an indication to directly either go for chorion villus sampling or amniocentesis. It is not an indication to repeat the test because you are not adding, there is no to the situation, there is no benefit of repeating the test again. It is a direct indication to go for diagnostic test. Now coming to first trimester aneuploidy screening, whenever it is called as first trimester aneuploidy screening, under that there is mainly Analyte testing and Nuchal translucency. So here SCG and PA-PPA is included. Along with that, Nuchal translucency. It is done from 11 to 14 weeks. Again, I repeat here, this SCG is pre-beta SCG. When it is done from 11 weeks to 14 weeks of pregnancy. What is happening in trisomy 21 is there is an increase in SCG, whereas there is a fall in PA-PPA. How I have remembered it throughout my career is H is for high. So whenever there is a trisomy 21, what is happening there is there is a high SCG. That if you remember, rest of the things are lower. That becomes easier for us to remember that with Down syndrome, always SCG is raised. So HH, high is for H, high SCG. Whereas with trisomy 18 and 13, there is a lowered SCG as well as PA-PPA. It is easier to remember that 18 and 13 leads to fall in both. Whereas with Down syndrome, there is a higher SCG, HH. H is for high, higher SCG, lower level of PA-PPA. Now we'll discuss about the nuchal translucency. It is measuring the translucent subcutaneous area between skin and soft tissue over the back of fetal neck. That is nuchal translucency. There is at the back of the fetal neck, transiently there is a collection of lymph that leads for a few weeks. That when you measure that, that is nuchal translucency. This collection of the fluid or the lymph there between the skin and soft tissue over the back of fetal neck, that gives this translucent finding. This is called as nuchal translucency. It is done between 11 to 14 weeks, and there are so many criteria, and there are usually the sonologist needs a special training and special certificate courses are now available so that there is a accuracy in measurement of this nuchal translucency. Some of the important criteria: fetus should be in mid sagittal plane, neck should be neutral, it should neither be flex or extended, so that so many times we find that it becomes sometimes time consuming for ultrasonologist to report NT. Margins of NT are to be seen. Insonation angle should be perpendicular to non-nuchal translucency. Image should be mainly showing the head, neck, and upper thorax. Amnion line should be seen separately. Widest NT space is measured. Mean of 3 is taken. That is how there are so many criteria so that the accuracy increases if we follow all these criteria. Abnormal is whenever NT is greater than or equal to 3.0 millimeters. NT needs to be differentiated from cystic hygroma. Cystic hygroma is a fluid-filled area with septations. So it is septate and it extends on the back, whereas nuchal translucency is limited to neck. Aneuploidy risk is 5 times greater with cystic hygroma as compared to increased nuchal translucency, and that is why it is important to differentiate between these two. Cystic hygroma is a direct indication to go ahead with either chorion villus sampling in early pregnancy or amniocentesis in second trimester. Increased nuchal translucency is also associated with increased risk of cardiac anomalies, and that is why it is an indication to do fetal echocardiogram. Nuchal translucency especially helps in multifetal pregnancies, because in multifetal pregnancies, if we see if there is abnormal reports, say with cell-free fetal DNA, or there is abnormal report with Analyte testing, still which fetus is abnormal, or whether both the fetuses or all the fetuses are abnormal. For that, this NT will help to differentiate between normal and abnormal fetuses. Coming to second trimester aneuploidy screening, it is also called as quad test, quadruple test, where, as the name suggests, we are measuring four chemicals. One is HCG, second is unconjugated estriol, third is alpha fetoprotein, and last is dimeric inhibin. Dimeric is where the two this both inhibin A and inhibin B both are measured together. That is why it is called as dimeric inhibin. In trisomy 21, again take the help of HIGH, that there is rise in HCG and inhibin. HI. Increase HCG, increase inhibin, lower estriol, lower alpha fetoprotein. Whereas trisomy 18, all the three are lowered. There is no role of inhibin in that, only HCG, estriol, and maternal serum alpha fetoprotein. All three are reduced in 18, whereas in Downs, apart from HCG, inhibin is also raised. So HIGH is the spelling for high, and that is how you remember that there is a rise in HCG as well as inhibin. Detection rate is lower whenever the maternal age is less than 35 years, or if there is a twin pregnancy, or if there is a multifetal pregnancy with triplets or greater than that, and whenever it is done without first trimester screening. If directly this quad test is done, detection rate is less. Standalone second trimester screening is where first trimester testing is not done at all. Directly patient say comes for late booking. Then what we do is a standalone second trimester screening. This is done only when there is a late booking. Otherwise, whenever a woman comes in the first trimester, genetic counseling is to be done in first trimester. Tests are to be offered, screening tests are to be offered in first trimester itself, so that there is then no question of going for a assessing only a standalone second trimester screening. Now, if we combine this first and second trimester screening, then in that case, if these two types are combined with each other, then the detection rate increases. It improves to greater than 90%, whereas if it is done alone, the detection rate is only around 80%. So there are, how we can combine is, there are mainly two ways. One is called as integrated screening, other is called as sequential screening. What you remember is, in integrated screening, we screen in first trimester as well as in second trimester, but we do not disclose the report of first trimester screening immediately. The assessment or the results are assessed in combination. So first we take the maternal serum in first trimester as well as we do NT. Then we take the maternal blood test and do the quadruple test in second trimester, and together we assess the risk. Combined result is assessed. Result is not assessed separately. That is integrated screening. Sequential screening has two types. One is stepwise sequential, where we divide the result in two groups, whereas in contingent sequential screening, we divide the result in, on the basis of result, we divide the patients in three groups. Stepwise screening is where we divide in two groups. If there is a low risk, then we have to go for second trimester screening. Low risk in the first trimester screening, where we do Analyte testing and NT. That shows low risk. It is an indication to proceed with second trimester screening. Whereas that shows a higher risk, it is an indication to directly go for diagnostic testing, that is chorion villus sampling, rather than waiting for second trimester screening. That is the meaning of this stepwise sequential, where we divide the women in two groups. Contingent sequential is where we divide in three groups after on the basis of first trimester screening result. In low risk, there is no need to repeat the testing in the second trimester. Moderate risk, you repeat in second trimester, Analyte test or quad test. You do quad test in second trimester. But in high risk group, you directly go for diagnostic testing. That is contingent sequential screening. So sequential is, if you divide in two groups, it is stepwise. If you divide in three groups, it is contingent. In contingent, there is a low risk group where there is no need to do the quad test. Place of ultrasonography. What is the place of ultrasonography in aneuploidy screening? Ultrasonography helps us to calculate the accurate gestational age, because all these analytes such as HCG, or if you take estriol, or you take maternal serum alpha fetoprotein or PAPPA, all these what the level changes from week to week, and that is why it is very important to calculate the gestational age accurately. That will improve the accuracy of our testing also. Diagnosis of multifetal gestation is possible by doing ultrasonography, so that with that we know that the accuracy of our screening is less. Detection of fetal demise is possible by ultrasonography. That will change the way we will be managing a woman. Diagnosis of major structural abnormalities is possible by ultrasonography, and some structural abnormalities are such that there is such a high risk of having a genetic abnormality that it becomes a direct indication to go for diagnostic testing. There is no need for aneuploidy screening in these cases. We proceed directly with either CVS, that is chorion villus sampling, or amniocentesis. With the ultrasonography, we can detect an empty gestational sac in one of the twin, and if it is detected, in that case, we know that these analytes or the testing by analytes is of less accurate, and it is not of use. In such a situation, we can then in such a situation we cannot rely on the testing, this testing. Detection of minor aneuploidy markers, which are also called as soft markers, is possible by doing ultrasonography. So these are the 6 advantages of doing ultrasonography whenever we want to do aneuploidy screening: calculate the gestational age, diagnose multifetal gestation, diagnose fetal demise, diagnose major structural abnormality necessitating diagnostic testing, diagnose a co-twin having a demise of a co-twin, empty gestational sac, so that again we know that the test can become false positive, Analyte test, and detection of minor aneuploidy markers, which are also called as soft markers. Now, major fetal anomalies are cystic hygroma, non-immune hydrops, ventriculomegaly, Hole-Prosencephalon, Dandy-Walker syndrome, cleft lip or palate, cardiac abnormalities, diaphragmatic hernia, esophageal atresia, duodenal atresia, omphalocele, and clubfoot. Now, with cystic hygroma, risk of aneuploidy is maximum 50 to 70%, whereas in all the remaining, the risk is greater than 10%. Some of these are having even the risk of around 30% also, so much more. Now, here we have to remember that omphalocele has a risk more greater than around 10% of aneuploidy risk is there, whereas if there is a gastroschisis, there is no increase in the risk of aneuploidy. That is the reason we need to differentiate between omphalocele and gastroschisis. And I hope that as students, you should be aware, you must be aware that if there is a membrane and with that the abdominal contents are out, it is omphalocele. And if there is no limiting membrane, then that is gastroschisis. Gastroschisis why it has a better prognosis is it has no increase in the risk of aneuploidy. All this aneuploidy risk is greater than 10%, and that is the reason it is an indication for diagnostic testing, and aneuploidy screening has no role if any of this condition is detected by ultrasonography. Now, what are minor aneuploidy markers? These are normal variants and not fetal abnormalities, but these are associated with slight increase in the risk of aneuploidy. If there is one single soft marker, single minor aneuploidy marker, that is called as isolated marker. Isolated marker is an indication for aneuploidy screening. Single marker can be present in 10% of euploids. Euploids is normal individuals having normal chromosomes. In 10%, there can be presence of single marker. If there are multiple markers found in the same fetus, then the risk of aneuploidy keeps on increasing. So how you remember is, for the brain we have two, that is brachycephaly, and choroid plexus cyst. On the face we have absence of nasal bone or hypoplasia of nasal bone or short ear. So ear and nose we can remember that way. Neck region there are two, such as there can be increase in nuchal translucency or second trimester increase in nuchal thickness. Coming to the chest region, in the heart also we can have either tricuspid regurgitation or echogenic cardiac focus can be there. In the heart also we have two. So remember, in pairs you can remember brain to face and neck together, face area, that is near nose and ear. So that you can form in your mind as a pair to remember. Neck region pair, NT and nuchal thickness. Choroid plexus is brachycephaly is a pair for brain. Absence or hypoplasia of nasal bone and short ear is for the face region. Neck region we have two. Coming to the chest, we have two, tricuspid regurgitation and echogenic cardiac focus. Now we come to the abdomen, where there can be echogenic bowel or there can be renal pelvic dilation. These two can be there. And in the umbilical cord, there can be a single umbilical artery, and that is also one up. So abdomen area, you can remember that there are three in the baby. One is related to the kidney, renal pelvic dilation. Second is intestine, echogenic bowel related to intestine, and third is umbilical cord having single umbilical artery. Now coming to extremities, upper extremity there can be a short humerus and there can be a short femur for lower extremity. You can pair it to remember like that. On the hands, single palmar crease is one, whereas clinodactyly is other. So remember it as in the pair, that on the palm there can be single palmar crease, and for the hand there can be clinodactyly, where there is an inward inclination of the little finger, inward bending of the little finger. Then coming to the again on the foot, there can be a sandal gap between the great toe and the second toe. That is how you remember from top to bottom. It is very easy to remember it in a pictorial manner like that. So that you, and this is important, I forgot to say, is ductus venosus is near the liver. In abdomen, you have four, as rest of the areas we have in pairs. Here we have four, one for kidney, one from intestine, one you can remember for umbilical cord, and one for near the liver as ductus venosus. There can be absence or reversal of A wave. The markers which I have made as star are seen in the first trimester. Tricuspid, apart from NT. NT is the important minor. It is minor aneuploidy marker, but it plays an important role when it is combined with Analyte testing in the first trimester. That is PA-PPA testing and SCG testing. So here, apart from NT, other three are nasal bone, tricuspid regurgitation, and ductus venosus, absence or reversal of A wave. Remember, if you are asked what are the minor aneuploidy markers in first trimester, these are the four. If you are asked what are the soft markers in second trimester, then you describe all the remaining along with this nasal bone is also there in the second trimester. It is for both first trimester as well as second trimester. Now this is about whatever is described in usually in the textbooks. Now what are the guidelines? What is the current thinking that we come to know whenever we go through the guidelines, and we have to as current as ACOG guidance 2025. What it says is prenatal genetic screening and diagnostic testing should be offered universally to all pregnant women, and preferably at the first antenatal visit. To all pregnant women, irrespective of maternal age or irrespective of risk of chromosomal abnormality. That is the meaning of this term universally. So, which, if you are asked, whether you will be offering the screening, aneuploidy screening to specific group of women, or whether you will be offering to all. What you do whenever a woman enters into your clinic, whenever you see antenatal patient, with you need to offer it universally. You need to counsel the woman about what are the tests, screening tests, what are the diagnostic tests, what are the possibilities, what are the limitations of tests, and what is the advantage of doing all these tests, all that, or what are the procedure related complications if diagnostic tests are required. All this should be discussed with a woman. You need to spend some precious time, and that is how you offer it universally. Prenatal genetic screening includes now, number one is serum screening with or without NT by ultrasonography. That is what ACOG says. You can do serum screening with or without NT, or you can do cell-free DNA screening. Diagnostic testing includes either chorion villus sampling or amniocentesis. After counseling and discussion, patient has the right to either pursue or decline the screening testing or diagnostic testing. That is patient's choice. For screening, any one method should be used. That means combination of this Analyte testing, serum screening, and cell-free DNA screening combination, that is not to be used because it adds to confusion. So either we have to do serum testing with or without NT, or we have to proceed with cell-free fetal DNA screening. Cell-free DNA has more sensitivity and specificity to detect common fetal aneuploidies, whereas if we compare for all the fetal aneuploidies together, the possibility of having a high risk group is greater if we do the this traditional analyte testing. Cell-free DNA testing is not a diagnostic test. Second trimester ultrasonography should be offered universally to all pregnant women for to do the structural analysis to detect structural defects in the baby, either major structural defects or soft markers. And this screening is to be done at from 18 to 22 weeks. It is irrespective of whatever is the result of the first or second trimester aneuploidy screening. This should be done along with or without maternal serum alpha fetoprotein, and it should be offered universally. Negative result of screening does not mean that fetus is absolutely not having, there is a zero possibility of having aneuploidy. That whenever we uh, give a result to a woman, we need to do again the genetic counseling, or we need to do the counseling to say that the screening can be associated with false negative results also, and that is why we cannot be very sure that baby is not having any aneuploidy. There are certain aneuploidies which might go undetected by this screening test. Positive test or no call result of cell-free fetal DNA is an indication to do genetic counts. Positive test result of either Analyte test or cell-free fetal DNA, or a no-call result of cell-free fetal DNA is an indication to do further genetic counseling, do ultrasonography in detail, and do the diagnostic testing. Positive Analyte test followed by cell-free fetal DNA is to be done only whenever for those who are not willing for diagnostic testing. Otherwise, there is no place of doing cell-free fetal DNA if the Analyte test result is positive. It is only for limited for those who are not willing for diagnostic testing. Isolated soft marker, and if it is associated with a negative Analyte test, there is no need for further evaluation. But if Analyte test is not done there is isolated soft marker, then we can proceed with cell-free fetal DNA, quad test, or amniocentesis after counseling. More than one soft marker is present is an indication to do the genetic counseling, and we can, if facilities are available, we can even refer the patient to maternal fetal specialist, where the interpretation of the result will be better. Whether to proceed with the diagnostic testing can be advised accordingly. Selfie fetal DNA is better than Analyte testing in multifetal pregnancies. First and second trimester Analyte only unlinked screening is not recommended. That is standalone first trimester Analyte, standalone second trimester Analyte testing, that is not recommended. This screening is either should be integrated or it should be, as we have already seen, it can be sequential, either stepwise sequential or contingent sequential, or it can be integrated. In multifetal pregnancy, if one fetus shows demise or vanishing twin is there, or one fetus shows anomaly, screening becomes inaccurate. In such a situation, we should be cautious whenever we will be interpreting the screening test result. To summarize, we should offer this aneuploidy screening at the first antenatal visit itself. Analyte based screening can be offered, or cell-free fetal DNA, depending on whether patient can afford or whether it is available. Analyte based, we divide it into first trimester and second trimester. First trimester, where we do PA/PPA with HCG along with Nuchal translucency. Second trimester is quad test. It is better to interpret the result as either integrated, that is together, simultaneously first and second trimester together, or sequential, where based on first trimester we divide the patients in 2 groups in stepwise and 3 groups in contingent. Ultrasonography to be offered universally to all women from 18 to 22 weeks of pregnancy to detect either major or minor markers. Major congenital malformations or minor markers are also called as soft markers. Major congenital anomalies is an indication to directly go for diagnostic testing, whereas if minor markers are there, only isolated single marker is an indication for screening, whereas greater than one, if minor soft markers are present, then the risk needs to be reassessed to mainly decide about the need of diagnostic testing. Minor we can divide into first trimester as well as second trimester minor markers. Approximate detection rate for trisomy 21, that if we see, that itself gives you the idea, that gives us the idea about various tests. For Analyte base, if standalone first trimester is done, that is PA/PPA, histriol and NT, PA/PPA, I'm sorry, PA/PPA, HCG and Nuchal translucency, then the detection rate is around 80% for trisomy 21. Second trimester standalone also is around 80%. But together, if we do integrated or if we do sequential, in that case, the detection rate improves to greater than 90%. Cell-free fetal DNA for trisomy 21, the detection rate is around 99%, very high. Now, the rate in general is more whenever the age of the woman is greater than 35 years, and the detection rate is less whenever the woman is younger. And the rate is more in singleton pregnancy as compared to the multifetal pregnancy or twin pregnancy. Thank you so much. I have gone through Williams obstetrics and taken the help of that mainly. Then current ACOG guidance 2025, as well as AAFP, American Association of Family Physician Guideline 2020. Thank you once again.